it was an extraordinary experience, but I do remember the cold of Rochester.
Yeah, it can be brutal.
But you have the exact opposite in Scottsdale.
Yeah, exactly. Exactly.
How many members does PCNA have now?
Oh gosh, I'd have to look at how many we're up to. I know it's well over. Gosh, it has to be like close to 700 or so, I think.
700.
I think I'd have to double check. Our membership's gone down during the pandemic.
Really?
Yeah. People are still going to our website a lot and downloading our free materials, but like some people have just kind of lost, dropped out their membership, and I don't know why. We're investigating that now.
Are you an officer?
I am. I'm on the board of directors, and I'm going to be president-elect starting in April. Yeah.
How long is your term?
So when I'm president, it'll be a year. So president-elect is a year, then president's a year, and then past president's a year. Yeah. So it'll be exciting. I'm
wrapping up my 4th presidency, and it's enough.
I bet. Well, I'm part of the NLA. I do a lot. I'm like the co-chair of the ICE committee for NLA. So yeah, I do a lot with them. Go to those meetings, which they're out here this year for the summer.
Yes.
Symposium, which will be great. I won't have to go far.
Well, the June meeting is in Phoenix.
I think isn't it, or is it going to be at the Westin again, or did they change the location?
I don't know.
Yeah, I don't know either. But it was when during COVID, it was supposed to be at the Westin, Kierland. But I don't know if they rebooked it there. It just says Scottsdale, I think. It doesn't.
Scottsdale.
Yeah.
Yeah, I was president of MLA and president of the ABCL.
Oh.
So I know the MLA very well.
Exactly. I think we're ready.
Well, good evening, everyone, and welcome to Hiding in Plain Sight, a focus on diagnosing and addressing the unmet needs in homozygous familial hypercholesterolemia. This program is being projected to you this evening by Integrity Continuing Education, and it is supported by an independent medical education grant from Regeneron Pharmaceuticals. Faculty presenters are Susan, Halli, Demeter, and me, Peter Toth. Our credentials are here, and our disclosures can be seen here. So what are our learning objectives this evening? Well, we're going to describe the prevalence of homozygous familial hypercholesterolemia and its underdiagnosis. We're going to talk about how to apply cascade screening in clinical practice as a cost-effective strategy to diagnose familial hypercholesterolemia in close relatives of patients already diagnosed with familial hypercholesterolemia. We're going to outline for you how to integrate currently available therapies with novel mechanisms of action into the treatment regimen of patients with homozygous FH. And we're also going to talk about how to increase accessibility of newer, low-density lipoprotein cholesterol-lowering therapies to patients with homozygous familial hypercholesterolemia. So let's start with some pre-test polling questions. Approximately what percentage of patients with FH are underdiagnosed? Is it 10%, 40%, 70%, or 90%? Please provide your response. A 28-year-old female patient was recently diagnosed with homozygous FH. She has 2 children and an older brother. Based on diagnostic screening criteria, who else in her family would warrant screening? Her children only, her children and her brother, all her first-degree relatives. No one else should be screened. A 27-year-old patient with a positive genetic test and confirmed diagnosis of homozygous FH is taking ezetimibe and rosuvastatin 5 milligrams every other day due to low tolerance of statin. Which of the following therapies would you recommend next? Bempedoic acid, evinacumab, just continue the rosuvastatin, or add inclyserin? You have prescribed a novel lipid-lowering therapy for a 27-year-old woman with recently diagnosed homozygous FH. Which tools will you provide to ensure adherence to therapy? PCSK9 monoclonal antibody or PCSK9 inhibitor prior authorization form, letter to family template, repeal request, A and C, or A and B? All right. So now we're going to kick the program off with an overview of familial hypercholesterolemia, heterozygous and homozygous. Susan, why don't you take us through this?
Thank you. Hang on. There we go. What is familial hypercholesterolemia? So familial hypercholesterolemia, or FH, is a heritable severe form of hypercholesterolemia involving a single gene. Clinical features on exam include cholesterol deposits in the tendons called xanthomas. FH can lead to premature cardiovascular disease and death before age 55. With homozygous FH, it is difficult to survive beyond age 30 without treatment. Most FH patients exhibit autosomal dominant inheritance. The 3 most common genetic mutations are the LDL receptor, which accounts for about 60 to 80% of mutations, mutation in ApoB, and a gain-of-function mutation of PCSK9. There are also less common mutations of the LDL receptor, ApoB, PCSK9, and ARH, or autosomal recessive hypercholesterolemia, which is caused by mutations in the gene coding of LDL RAP1 gene, which is LDL receptor adapter 1. There are over 2,000 variants, and approximately 20 to 40% of mutations cannot be identified in patients diagnosed with FH. The pathways affected are sterol metabolism and lipoprotein metabolism with varying gene dose effects. FH is the most common gene disorder in lipoprotein metabolism and can be found in all races and ethnicities. Only 10% of individuals born with FH are diagnosed, and want to stress that this condition is underdiagnosed and undertreated in the general population. The exact U.S. prevalence of FH is unknown. A study by Ferranti and colleagues in 2016 reviewed the 1999 to 2012 NHANES data to estimate the prevalence of FH using the Dutch Lipid Clinic Network diagnostic criteria, and concluded approximately 1 in 250 U.S. adults have FH. The 2 FH disease types are heterozygous, which typically affects one allele, and homozygous affecting two alleles, or a compound heterozygous who has two different mutations. So this is the two pathogenic variants, heterozygous FH and homozygous FH. Heterozygous FH is more common and often caused by heterozygous mutations in the gene encoding of the LDL receptor. One mutation is passed down to the child, typically from one parent. The physical findings are similar to homozygous FH, but less prevalent. Homozygous FH is rare, affecting 1 in 170,000 to 300,000, and more severe with homozygous mutations. Two mutations are passed down from both parents to the child. The plasma LDL can be similar to significantly higher than those with heterozygous FH, and the LDL is typically 4 times greater than normal values. The prognosis with homozygous FH is poor compared to heterozygous FH. Physical findings include cholesterol deposits in the corneas, eyelids, and extensor tendons. Coronary artery disease and vascular disease is accelerated in these patients. Patients do not or poorly respond to medications to enhance activity, and often require multiple medications or sometimes LDL apheresis. Family studies and genetic testing are encouraged to help with distinguishing heterozygous FH or compound heterozygous FH from homozygous FH. Children of a person with FH have a 50% chance of inheriting this disease. Early screening of parents, siblings, and children of a person diagnosed with FH can help save lives, and cascade screening helps identify and inform those at risk. I oftentimes refer patients to genetic counseling, which is very helpful in the screening process and testing for FH. Now, Dr. Toth will discuss screening and diagnosing FH patients.
Are you missing the diagnosis? Susan, thank you so much. So early screening and diagnosis of FH and its variants. Well, the name of the game here is to identify as early as possible and drop the LDL as far below the floor as you can. How do I want you to view LDL? Well, it's basically spent garbage lipid. There's really nothing you do with LDL cholesterol. You don't need much LDL cholesterol in your blood. It really doesn't contribute to intermediate metabolism. Every cell in your body is capable of producing its own supply of cholesterol. And if you have too much of it, what happens? Well, it accumulates in the intima and the arterial wall and drives atherosclerotic disease. We know that if there is little to no LDL, there is no atherosclerotic disease. So among patients with FH, especially homozygous FH, we know that they have high LDL levels from birth. And in fact, for unfortunate fetuses that died in utero, they already have fatty streaks and can have nascent lipid-rich plaques forming in their coronary vasculature before they're even born. Of course, the disease is progressive with early onset at less than 10. And actually, for patients with more severe homozygous FH, it's not extraordinary for them to require a bypass by the age of 6 to 8. Yep, you heard that here, 6 to 8. CAD-related mortality is, of course, more common in the second decade. And if untreated, ASCVD mean age is 12.5 years. So this is a dreadful disease. And the higher the baseline LDL, the higher the risk for developing premature multivessel disease. Also, the higher risk of dying at a very young age. Young adults with FH have about a 90-fold increased mortality due to ASCVD. Now let's take a look at the panel on the right. If you look at an untreated homozygous patient with FH, you'll notice that they cross this so-called event horizon, that flat purple line, at about the age of 12.5%, which means that they either have clinically significant atherosclerotic cardiovascular disease or they've had an event. Now, if you take a look at the line that says start low dose statin. And you take a look at the start high dose statin. And you look at the heterozygotes. What happens? You are shifting the event horizon progressively more to the right the more intensively you treat. Now, what's the clinical meaning of this? For a heterozygote who perhaps manifests with disease by age 35, their event horizon declares itself at age 48 with low-dose statin. And if you go with high-dose statin, it's more like 53 years. The lower you drop the LDL, the farther to the right you're going to shift that event horizon. And that's the most important thing we could probably tell you tonight is identify early, treat very aggressively to guideline standards, and you're going to do this patient an enormous, enormous service. So what does it look like? Well, we have cutaneous xanthomas. If you look at the creases in the wrists and the ankles of this child in the top on the left, it just stares you in the face. Now, if you look at tendon xanthomas in this adult, looking at the hands, the Achilles tendons, there is a massive amount of cholesterol being deposited along these tendons. And then, of course, we've all seen xanthelasmas, which is going to be the deposition of cholesterol within the eyelids. There can be corneal arcus, which this is a very beautiful example of corneal arcus. And once a patient has significant obstructive disease, then, of course, they can manifest the usual symptoms of coronary disease, such as angina. They may manifest evidence of claudication with cramping or pain in one or both legs. They may have poor wound healing, and they may have sudden cardiac events, not just MI, but also ischemic stroke and sudden cardiac death. So how underdiagnosed is it? Oh my goodness. 90% of individuals with FH in the US are underdiagnosed. And of course, there are many countries in the world where that number is far higher. Now, in countries like the Netherlands or in Quebec in Canada, that number is dramatically lower because the prevalence of FH is so high, it is routinely screened for. But 1 in 500 to 1 in 200 individuals worldwide have FH. This makes it among the most commonly occurring genetic disorders in the world. Every person listening to us this evening has patients with heterozygous FH. You may have one patient with homozygous FH. Odds are the patients you have homozygous FH. So actually, this is a very relevant discussion to any primary care or cardiology or endocrinology practice anywhere in the world. Unfortunately, children are often not screened, and it is currently recommended that all children be screened by age 9 to 11, much earlier if the physician or the clinician treating the patient knows that the parents may have a history of homozygous FH. And in the US, cascade screening is not systematically performed, which is unfortunate because cascade screening has been found to be both cost-effective and highly efficient at identifying patients with FH. There is urgent worldwide need for diagnostic screening and early aggressive treatment to reduce CHD and death. And what are some of the barriers to FH diagnosis? Well, this includes low levels of pediatric lipid screening. Pediatricians, unfortunately, typically do not screen for FH, and it does need to be done. Lack of diagnostic criteria built into electronic health records to facilitate FH identification, and lack of clinician education on FH screening and diagnosis guidelines. So how does the American Heart Association view this? How do the guidelines from AHA help us to identify adults and pediatric patients with FH? Well, heterozygous FH for children is diagnosed if the LDL is above 160 milligrams per deciliter. For adults, it's 190. And actually, that's also consistent with what the international guidelines have stated. For homozygous FH, typically LDL is going to be over 400. This also means that one or both parents having clinically diagnosed FH, there should also be positive genetic testing for an LDL cholesterol raising gene defect or autosomal recessive FH. Another very important consideration for patients with FH, especially if they have homozygous FH, is premature aortic valve stenosis from massive deposition of cholesterol into the valve. And we know that these patients have an inordinate risk for developing aortic valve stenosis. The higher the LDL, the bigger the risk. For a family history of FH, presence of a first-degree relative with confirmed FH, LDL cholesterol is not a criterion. Now, what is currently recommended? If you can do genetic testing, it's a good idea the world over, because we are finding that there are many, many private mutations, founder mutations, and just because there's a company that may look at the 8 most commonly occurring mutations, the diagnosis may be missed. So with over 2,200 current genetic variants with the diagnosis of FH, it does turn out to be important to do whole gene sequencing for the LDL receptor, ApoB, and for PCSK9. Why is genetic testing important? Because it's an opportunity to help identify FH and prevent CHD. Benefits: promotes a definitive diagnosis of FH and its subtypes of heterozygous and homozygous FH, eliminates the need to investigate secondary causes of high LDL, identifies pathogenic variants correlated with higher CV risk, and higher CV risk requires more aggressive intervention with more intensive lipid-lowering therapies, improves initiation adherence to lipid-lowering therapies to delay major cardiovascular events and early death, and cascade testing, without question, identifies at-risk relatives, helps diagnose and treat proband index cases. Barriers: cost. I will tell you that the cost of genetic testing continues to decrease. More insurance companies are covering it. Yes, it may impact cost for life insurance, and there may also be a belief that results will not change treatment decisions. But in fact, studies have shown that it does. So, cascade screening. So, homozygous FH appears in clusters of relatives of patients with homozygous FH. Cascade testing identifies the FH proband, followed by subsequent testing of all at-risk relatives in a cycle. It's repeated through the family unit until all at-risk individuals are tested. So what are some of the benefits? Improved FH diagnosis, cost-effective diagnostic strategy, initiation of preventive interventions at a younger age, increased adherence to lipid-lowering treatments, and improved patient outcomes with a reduction in risk for premature MI, premature death, the need for premature aortic valve replacement, as well as reduced risk for ischemic stroke. Also, reduced risk for peripheral arterial disease. What are some barriers? Well, suboptimal self-reporting of family history, lack of appropriate communication between probands and family members, concern about stigma associated with diagnoses of genetic disorders, or concern about potential implications on employment or health insurance coverage. The bottom line is, I think you would agree that for the most part, the benefits here certainly outweigh the barriers and the risks. Okay, Susan, let's switch to you.
Okay, so now I'm going to review treatment strategies and guideline recommendations to optimize lipid management in patients with homozygous FH. So for the treatment of homozygous FH versus heterozygous FH, initial therapy for homozygous FH is identical actually to that of heterozygous FH. Typically, initiation of a statin plus or minus ezetimibe is the universal guideline recommended first-line therapy in patients. Statins and ezetimibe may prove to be less effective because mechanism of action largely depends on upregulation of functional LDL receptors in the liver. In homozygous FH, measurable activity of both copies of the LDL receptor are absent or greatly reduced, causing drug-induced LDL lowering to be diminished by greater than 50%. Comparing heterozygous FH to homozygous FH, high-intensity statins lower LDL 50 to 60% versus 10 to 25%, and ezetimibe lowers the LDL by about 15 to 25% versus less than 10% respectively. In addition to LDL lowering therapy, always reinforce the need for healthy lifestyle, such as following a healthy dietary pattern, engaging in regular physical activity, promoting weight loss if a patient is overweight or obese, and avoidance of tobacco. The 2018 AHA-ACC Multi-Society Cholesterol Guideline provides this algorithm for managing patients with homozygous FH. Powerful LDL lowering is required from a young age to prevent onset and progression of coronary artery disease. This algorithm includes statins, ezetimibe, PCSK9 inhibitors, MTP inhibitors, resins, probucol, and LDL apheresis. However, guideline updates are now needed to reflect the new and emergency therapy options that are available. So let's now examine the standard lipid-lowering therapies along with unmet treatment needs for patients. So I will briefly, summarize this table for the sake of time. But statins, have extensive evidence of their benefits in reducing cardiovascular risk by lowering LDL and other atherogenic lipoproteins such as ApoB. Most common reported side effects are myalgia, and they are relatively ineffective in homozygous FH patients with reduced LDL receptor activity. You also need to be mindful of potential drug-drug interactions. Ezetimibe inhibits absorption of dietary cholesterol by blocking Niemann Pick C1-like-1 protein. When added to a statin, it can reduce LDL by an additional 15 to 20% and found CV risk reduction benefit in the Improve It trial. It carries minimal side effects, and oftentimes it's GI. Bile acid sequestrants are rarely used, but patients may prefer them in the pediatric population because it's not systemic. Although the primary direct action is to bind bile acids in the gut, their interruption of enterohepatic recirculation of the bile acids has important effects on hepatic lipoprotein metabolism. They can lower LDL by about 23 milligrams per deciliter and can lower glucose and hyperglycemia. One CV outcomes trial did show some CV risk reduction as monotherapy, but just keep in mind that it can raise triglycerides as a side effect and often can cause constipation. PCSK9 inhibitors offer substantial LDL lowering of about 60% and found reduced cardiovascular risk in the Fourier and Odyssey trials. These are injectable medications every 14 days and cost approximately $5,850 a year without insurance coverage. All these medication options may have little to no effect from the increased LDL receptor function in FH patients. Lipoprotein apheresis is a procedure that can be used as an option to remove LDL from the plasma and is an invasive procedure that can take 1.5 to 3 hours every 14 days or so. The frequency of treatments can affect quality of life, and it is expensive, and it can be hard to find a site where it can be performed, and patients sometimes drive quite far for treatment. So just to briefly review, with the PCSK9 inhibitors, evolocumab and alirocumab, in the Fourier trial with evolocumab, the median baseline LDL decreased 59% from 92 milligrams per deciliter to 30 milligrams per deciliter, with a significant reduction in cardiovascular death, MI and stroke, as well as hospitalization for unstable angina and coronary revascularization at 48 weeks, as you can see, with a hazard ratio of 0.85 and a 95% confidence interval with a p-value of less than 0.001. And then as you see, the Odyssey trial with alirocumab had similar findings with a median follow-up of 2.8 years. So now I'll move into the limitations of standard care lipid lowering treatments. The MTP inhibitor lomitibide requires close monitoring of hepatic function with gradual up titration as tolerated. It can cause liver toxicity and also cause significant GI side effects. Prescribers need to be certified to prescribe it, and it is approved with risk evaluation and risk mitigation strategy. As mentioned on the previous slide, FH patients may see little to no benefit from statins, PCSK9 inhibitors, bile acid sequestrants, and ezetimibe, where LDL receptor activity may be lacking. Homozygous FH mutations are often LDL receptor negative or defective. These patients often do not reach their LDL levels, to optimal ranges of 70. LDL apheresis offers a temporary reduction in LDL, requiring regular invasive treatments that raise healthcare costs and is quite expensive. It is best to perform treatment while also on a medication regimen for best results. LDL apheresis is not a desirable option and can greatly affect a patient's quality of life. There are limited healthcare centers that offer the apheresis. And like I said earlier, people sometimes travel hours just to go have a treatment performed. I will now hand the presentation back over to Dr. Toth, who will discuss newly approved therapies to optimize patient outcomes.
Thank you, Susan. Well, lipids never sleep. Neither do researchers working on novel approaches to reduce atherogenic lipoprotein burden in serum. So do we have some exciting new members of the lipid-lowering class? The answer is yes. And they all work by different mechanisms. The first one is evinacumab, which is an angiopoietin-like protein 3 inhibitor. And angiopoietin-like protein 3 is very interesting. It actually inhibits lipoprotein lipase and endothelial lipase. And that, of course, blocks the capacity of hepatic VLDL particles to be stripped of their triglycerides, for those triglycerides to be hydrolyzed, and to actually form LDL in serum. Now, evinacumab is an infusion. It was approved by the FDA in 2021. It is used as an add-on therapy for adult and pediatric patients over the age of 12 years old with homozygous FH. And it's dosed at about 15 milligrams per kilogram. And it is truly a remarkable breakthrough in the field of lipidology. Inclyserin is a novel PCSK9 inhibitor. And it's novel because, unlike the monoclonal antibodies, which function outside the hepatocyte and neutralize PCSK9 in the extracellular milieu, inclyserin is an oligonucleotide that is specifically targeted to the liver. The hepatocyte takes it up, and the inclyserin functions as a silencing RNA by shutting down the translation of PCSK9 messenger RNA into PCSK9 protein. Now, silencing RNA is an extraordinary technology, but it's also based on a very primitive and highly conserved approach by eukaryotes and prokaryotes to prevent parasitic and invasive RNAs from taking over the cell. This goes back eons. And just so you understand, there's over 54 kinds of RNA in our bodies. And silencing RNA is a critical means by which there's actually action at a distance with communication between cells and distant regulation of gene expression from one cell type to another. So I don't want people to be intimidated by this because it's actually based on an ancient mechanism of action. We're just putting it to therapeutic use. Inclyserin is an injection. Its effect on cardiovascular morbidity and mortality has not yet been determined. And it was just approved in December of last year. Bempedoic acid is also a fascinating medication. Bempedoic acid is an ATP citrate lyase inhibitor, and it can be used in combination with any other lipid-lowering medication. It is effective and well tolerated for reducing LDL cholesterol, and we'll take a closer look at its mechanism of action in just a few slides. So we have different molecular targets. Evinacumab is a monoclonal antibody that neutralizes angiopoietin-like protein 3. Inclyserin is a silencing RNA that promotes the destruction of PCSK9 messenger RNA. And bempedoic acid is an ATP citrate lyase inhibitor, a very important enzyme in overall sterol metabolism. So let's talk about evinacumab first. As all of you know, in order for LDL to be formed in serum, its parent lipoprotein is actually VLDL. VLDL is the principal energy-rich lipoprotein that is produced and secreted by hepatocytes. And it's energy-rich because it's carrying triglyceride. Remember, the cholesterol in lipoproteins cannot be catabolized by any cell type in your body except for the hepatocyte. It cannot be used as a fuel by any cell type. And hence, it's triglycerides that are the important contributor as an energy source in intermediate metabolism. The triglycerides are stripped away by lipoprotein lipase and endothelial lipase, and they are broken down to fatty acids, which are readily taken up by cells. They're burned as fuel in the mitochondria. This needs to be a very efficient process so that VLDL can be turned into IDL and then LDL. Well, if you have a lot of angiopoietin-like protein around, this doesn't happen very efficiently. In fact, it doesn't happen very well at all. And you accumulate what we call remnant lipoproteins, which are smaller VLDLs. They're intermediate density lipoproteins, as well as some low density lipoprotein. All of this is atherogenic. And in patients with FH, all of it contributes to risk. So where did they get this idea that perhaps using an angiopoietin-like protein inhibitor might work? Well, it's because loss of function variants in the gene for angiopoietin-like protein 3 are associated with low levels of LDL and triglycerides, a 41% average lower risk of CAD, and this has been shown in multiple genome-wide association studies and Mendelian inheritance studies. So the proof of concept was there. So when you actually innovate and you develop a monoclonal antibody directed against angiopoietin-like protein 3, what happens? LDL drops, and it drops by about 50%. Now, you ask the question, how in the world can a drug drop LDL 50% in homozygotes if they're not expressing the LDL receptor? Because at least theoretically, if someone's homozygous for FH, they're not expressing the LDL receptor. Well, it turns out that, in fact, most homozygotes still have some residual capacity for LDL receptor expression. It's not very high, but there's some. Some truly are null mutants. But something else appears to take over, and that is that other cell surface lipoproteins can also pop up. And these include the LDL receptor-related protein, the ApoE receptor, the VLDL receptor. And if the patient has this spectrum of atherogenic lipoprotein in their blood, these receptors come in handy because they each bind a specific range of lipoprotein. And hence, you see this 50% drop in LDL, but you also see reductions in other atherogenic lipoproteins as well. So this is really ingenious. I love the mechanism, and it's a truly wonderful addition to the treatment of homozygous FH. When you look at adverse events, compare placebo to evinacumab, you'll notice that there may be small differences, but bottom line is it has been very well tolerated. Let's take a look at inclisiran. So inclisiran, you'll have to follow this figure pretty closely. Inclisiran is an oligonucleotide that is bound to what we call triantennary N-acetylgalactosamine. Now, boy, that's a mouthful, isn't it? Why? Because this allows for inclisiran to very specifically be taken up by hepatocytes. Hepatocytes express between 500,000 and 1 million cell surface acyl or glycoprotein receptors, which actually very specifically bind N-acetylgalactosamine. No other cell type expresses the ASPGR receptor. So you're very specifically directing inclisiran into the liver, and inclisiran concentrates within clathrin-coated pits. It is taken up within endosomes. The clathrin on the outside dissociates once it's in the cytosol, and the inclisiran is now released into the cytosol, where it is able to associate with what we call an RNA-induced silencing complex, or a RISC complex. Okay, now this thing is a molecular beast, but suffice to say that the oligonucleotide that you have now incorporated into the RISC complex is stabilized within the RISC complex via a set of what we call Argonaute proteins. And what happens next? You unwind the oligonucleotide, and the sense strand dissociates. The antisense strand remains associated with the RISC complex, and now the antisense strand has sequence homology with the messenger RNA for PCSK9. You form a Watson-Crick double helix, and what happens next? Very specific RNases hydrolyze the complex, and you destroy the messenger RNA for PCSK9. What happens then? Well, you take advantage of any residual LDL receptor expression capacity that the patient may have. And actually, when you look at patients treated with PCSK9-based mechanisms, homozygotes still can have a remarkable potential for dropping LDL in response to treatment with these drugs. So what do you see? Well, inclisiran, when looked at in Orion 10, this was a phase 3 international trial with 1,550 patients with ASCVD, elevated LDL on maximal statin and ezetimibe. And in these patients, they observed about a 50% reduction in LDL. In patients with homozygous FH, it will not be this much, but it may still be a significant contribution to the overall treatment of the homozygous patient. Safety, again, very well tolerated. It's an injectable drug, and hence you do expect to see some percent of injection site reactions. But when you look at the usual culprits like arthralgia, pain in extremity, pretty close. Now let's take a look at bempedoic acid, an ATP citrate lyase inhibitor. So what does ATP citrate lyase do? Well, ATP citrate lyase is actually a critical enzyme in intermediate metabolism because it integrates lipid and carbohydrate metabolism. If you recall, when you oxidize fatty acids through beta oxidation, or you allow glucose to pass through the Embden-Meyerhof pathway, you form acetyl-CoA. The acetyl-CoA condenses with alpha-ketoglutarate to form citrate, and you go through the Krebs cycle. But if the demand arises, ATP citrate lyase can be activated, and it actually converts citrate back into acetyl-CoA and alpha-ketoglutarate. And acetyl-CoA, of course, is a building block for the steroid nucleus for cholesterol. It's also the basic building block for fatty acid. So inhibiting ATP citrate lyase would be a truly ingenious approach toward inhibiting cholesterol as well as triglyceride biosynthesis. So the clear clinical development program for bempedoic is shown here. And you'll notice that typically you get around a 16 to 24% reduction in LDL cholesterol. And if you combine it with ezetimibe, that number increases to about 36 to 38%. So another mechanism, another molecule to keep in your toolkit, and certainly choice is wonderful because different strokes for different folks makes a great deal of sense in the world of lipids. If you look at what are the principal side effects, hypouricemia with the potential for gout is real. Now, typically, if I'm going to use bempedoic acid, I do check a baseline serum uric acid, and if it is elevated, I'll probably treat it. And then there's also a risk for tendon rupture. Both of these issues are being investigated, but bottom line is the hyperuricemia arises because the bempedoic acid also inhibits the urate translocase on the proximal tubular epithelium. Okay, and now I'm going to give it back to Susan on the important role of patient education resources in the treatment of homozygous FH. Take her away.
Thank you. That was excellent. So we're going to move into, just some practical strategies to help improve, patient adherence and outcomes, which is so important to help work with these patients, get their LDLs better controlled, and help prevent future cardiovascular events in these people. To streamline the reimbursement process for new lipid-lowering medications, healthcare teams may provide patients with education about testing and treatment options, including brochures and infographics. There's also online FH toolkits at the FHfoundation.org website. And this includes toolkits on testing, treatment, shared decision-making between the provider and the patient, and then some help with insurance and insurance guides. There's also online FH insurance guides, just to kind of help with the cost perspective, and that a lot of these medications and treatments can be quite expensive, and help with the insurance coverage and process. Another great resource is on the ASPConline.org website, which is the American Society for Preventive Cardiology website. And that is also a great resource. Patient tools to improve family communication and uptake of cascade testing. On the FH website, you will see Dear Family letters. These can be sent to first-degree relatives, providing information about FH and the rationale to go ahead with evaluation and treatment. There's also online conversational guides, like how to prepare for a telehealth visit and what questions to ask your provider. There's also a great resource on finding an FH specialist, and they have a map of specialists in your area that you can refer to. There's also blogs highlighting shared personal stories, and I have many patients that have participated in these blogs and find it very helpful. Educational videos as well as webinars are available, and up-to-date news articles. So these are the forms: removing cost barriers to optimal therapy, prior authorization form, and the repeal request letter template. And these are just examples of these forms that they can help dramatically with the prior authorization process. And trust me, I've used them and highly recommend them. So, go to the ASPC app or website to use these, because when you fill out the prior authorization paperwork that's required by the insurance, you'll want to attach these to help support your case and any other clinical documentation you have to help get that prior authorization process. And it also just helps with compliance, making sure patients get the treatments they need. This is just an example of the personal letter to family members that can be found on the Family Heart Foundation or FH Foundation website. The Family Heart Foundation provides a variety of downloadable resources to help patients communicate with family and navigate diagnosis, treatment, and insurance to improve patient outcomes. And then the NLA, the National Lipid Association, as well as ASPC websites also offer practical tools to provide guidance on identifying the right patients for the right therapies and eliminate associated barriers of use. These are just some examples noted here. And then also, download the ASPC app, and that will also help to promote prevention of CVD, provide patient and clinical education, and is a great resource. I highly recommend it. So now we're going to proceed optimizing lipid management in patients with homozygous FH, and we're going to move into a patient case. So this is Anna. Anna's a 32-year-old female who has her cholesterol screened as part of annual physical exam. She presents with complaints of heart palpitations and some, left-sided chest pain that's been going on over the last several months. You don't notice any physical signs around the eyes or on her skin, but as far as her history, her LDL is consistently high, and by high, over 400, which is markedly high since initiating annual screening at age 22. She was directed not to worry about the LDL because her HDL was also high, and that was what her primary care provider had said. She has no known history of prior cardiac event that we know of. She is a smoker. She has a strong family history of premature cardiovascular disease and cardiovascular disease-related death. Her father died at age 38. A brother had an MI at age 32. Did not previously report family history of cardiovascular disease at a prior visit. She does have an 11-year-old and a 2-year-old sons, and she does not plan to have any additional children or any future pregnancies. So Anna then completed FH genetic testing at a CLIA lab that offered the panel, including the LDL receptor, ApoB, and PCSK9 mutations. And she was positive for DNA sequence analysis showing 2 mutations in the LDL receptor gene. Her cholesterol is 412, extremely high. And with her chest pain and symptoms, she was referred to interventional cardiology, who performed an angiogram that showed widespread CAD that required the placement of 3 stents. Anna met the following definite FH diagnosis criteria, which includes the Simon-Broom criteria. The positive genetic testing, though, was sufficient. And then, she had a very high Dutch Lipid Clinic Network diagnostic score, plus she had the additional elevated LDL that confirmed that diagnosis. So she was diagnosed with homozygous FH, and then the plan, was to have her use the Dear Family letter to help screen first-degree relatives for risk of FH. And so, what do you think as far as moving forward with her?
Oh my God. This is not a case you want to miss. She had 10 years worth of LDLs over 400. And, unfortunately, this is also an example of a young woman. Probably she told someone that she was having chest pain, and it probably wasn't taken seriously because of her young age. Mm-hmm. And so there are some fundamentals here, and bottom line is clearly right out of the gate, anything over 400 you have to assume is homozygous. And if the clinician had done the lipid profile, and seen an LDL of 400, instead of saying, don't worry about it because your HDL is high, they should have jumped all over this. Now, I'll tell you right now, no one in cardiology looks at a high HDL as necessarily protective anymore. And it certainly would not protect you against an LDL of 412.
No.
So bottom line is, this is a major blunder. But in the end, she was appropriately treated, but so much of her disease burden probably could have been prevented, at least to some degree.
Yeah. So what do you tend to, initiate? Do you start, high intensity, statin, Zetta, do you?
Well, yes.
All those and
this young woman would warrant high intensity, high dose statin because of her underlying coronary disease.
Yes.
And I would most certainly add evinacumab, which provides a very reliable 50% or more reduction in her LDL. And Inclyserin is not going to give her that in a homozygote, because Inclyserin still does rely on the LDL receptor.
Yeah.
And so I think high dose statin, evinacumab, and you take it from there. She's going to need 4 or 5 drugs.
Yeah.
But bottom line is, they saved her in time. And because of our newer drugs, you can really begin to select what you're going to use as adjuvant therapy once the evinacumab and the, let's say, rosubastatin or atorvastatin are put on board at high dose.
Yes. Agreed. Now we're going to move into where she's at 6 months. So her LDL is improving and she's responding. Now this is, she has the evinacumab on board along with the high intensity statin, and her LDL is 138. It's still not, quite as low as we would like it, but it is better. Would you add anything further here? What would you do next?
Oh, I would absolutely add something further, and I would definitely consider the addition of the combination of bempedoate with ezetimibe. Under the best of circumstances, it may get me close to 100. But again, you don't know. You have to try. It's trial and error. I don't know yet how much insurance would balk at using 2 monoclonals. All right. But that's another option here, because we know from trials with evolocumab as well as alirocumab that in patients with homozygous FH, there was on average a 33% reduction in LDL. And if you can reliably get that in homozygote, that's a pretty effective therapy. Yeah. So definitely, but I don't think anyone has experience yet in using evinacumab and a PCSK9 monoclonal together. We'll see data come out on this.
Yeah, over time. Yeah, so some clinical pearls for the treatment of homozygous FH. One, provide early identification. You want to try and diagnose and find this early, and provide early treatment and treat aggressively. Adjust treatment appropriately if LDL is not improved or you're not at therapeutic target or levels. Incorporate newly approved and emerging therapies and treatment plans as appropriate. Ensure that the cascade screening of all first-degree relatives occurs and follow up on that. And then, provide shared decision-making, patient resources, and tools as we discussed today.
All right, so let's sum things up here. What did we do? We talked about the importance of aggressively managing severely elevated LDL cholesterol levels in patients with homozygous FH to reduce early onset ASCVD and cardiovascular mortality. We talked about the importance of genetic testing and cascade screening for FH. We talked about the current standard of care therapies, as well as limitations for LDL lowering in patients with homozygous FH. And finally, we talked about newly approved agents with demonstrable potential to improve outcomes for these patients. So let's do the post-test polling. Okay, guys, do us proud. Approximately what percentage of patients with FH are underdiagnosed?
It's looking good.
Looking good. Yeah, I'd say 96% getting it right is pretty darn good. Remember, guys, we did explicitly state 90% are undiagnosed. Okay, next one. A 28-year-old lady is recently diagnosed with homozygous FH. She has 2 children and an older brother. Based on diagnostic screening criteria, who else in her family would warrant screening? Her children only, her children and her brother, all her first-degree relatives, no one else should be screened. Man, you guys are good. Look at that.
We have a smart group.
Yes. Yeah. Give it just a minute. We've slowed down, but looking good. All right, let's go ahead to the next one, just for time's sake. A 27-year-old patient with a positive genetic test and confirmed diagnosis of homozygous FH is taking ezetimibe and rosubastatin, 5 milligrams every other day due to low tolerance of statin. Which of the following therapies would you recommend next? Bempedoic acid, evinacumab, continue the rosubastatin only, or add inclyserin? I know, Susan, you gotta love these guys. Whoa, whoa.
They're doing great.
You have prescribed a novel lipid-lowering therapy for a 27-year-old woman with recently diagnosed homozygous FH. Which tools will you provide to ensure adherence to therapy? PCSK9 inhibitor prior authorization form, letter to family template, repeal request, A and C, or A and B? And when all is said and done, Susan, I'm going to ask you to comment on this because you covered this.
Yeah, so we'll give them a couple more minutes here, but this one they might just need a little bit of help on. So I do think everyone's pretty much done. Yeah, so, with this one, you're going to want to do the prior auth form and then the repeal request. The letter to the family template is more to help with screening and getting other first-degree family members diagnosed. You're going to want to use the PCSK9 prior auth form and the repeal request letter template to help with getting the prior authorization, helping patients get on therapy, and hopefully be adherent to therapy as well.
Okay, next question. Okay. So that leaves us maybe with a couple minutes for questions. We have no questions so far. Susan, believe it or not, we finished exactly on time.
I know, that's amazing.
Okay, our handouts of this presentation available. That's a good question. I don't know if the presentation is downloadable as a PDF or not. Donna, can you comment on that? Okay. Do you ever use high-dose statins when treating patients with FH, heterozygous or homozygous? Absolutely.
Yeah.
Absolutely. Heterozygotes virtually always as tolerated, and then the homozygotes almost always, especially if they have established underlying atherosclerotic disease or they've had a stent or they've been revascularized. What do you think, Susan?
Yeah, definitely.
Okay. Yeah. And then, Susan, why don't you explain cascade testing again?
Okay, so yeah, basically, that's going around to, all blood relatives. Usually, what I do when I have patients that have FH is I'll refer them to our genetic counselor. So I have access to someone that can help out with this, but they will meet with the patient. They'll kind of look at, the family members in the family tree and who had high cholesterol. They'll help with facilitating, the screening of any first degree relatives, second, any blood relatives that could possibly have this trait, and they'll try to help with that process. And so, it's oftentimes, like I said, done with a genetic counselor who's available, and we'll look at, which family members specifically had elevated LDL cholesterol that could be carrying down that trait. And as if you have the trait, there's a 50-50 chance you can pass it on, to your children. So I always, tell people, make sure you have them screened.
And audience, please know that all attendees will receive a link to the Homozygous FH resource tools, so you can use them in your practice. You can download them and use them in your practice. And then we'll take one more question, and that is, can your LDL be too low? And the answer is no. This has been looked at pretty exhaustively now. And bottom line is, the lower you go, the bigger the benefit in terms of cardiovascular endpoint reduction. But there's also no price to pay in terms of increasing risk for neurocognitive impairment, or for hemorrhagic stroke, or for loss of capacity to produce and secrete steroid hormones. There's plenty of cholesterol to go around, and in fact, in virtually everyone, it's too much. Right now, the going estimate for what a truly physiologic LDL is probably around 38 milligrams per deciliter. So with that, we're going to close because we're over time. I want to thank everyone for being on this teleconference this evening. I hope that you found this to be of educational value, and that you'll be able to take this back to your practice and apply it to everyday care. And Susan, thank you for your insights. Thank you.
Thank you.
Please stay online. You will automatically be redirected to the program evaluation so you can request credit. For viewers on social media platforms, please use the link provided to complete the evaluation and request credit. So don't leave yet. And I think with that, we're